Welcome, everyone. This is an important webinar. We're glad you're here. A look at Montana's state employee health plan savings from reference-based pricing. A couple of just housekeeping details to begin. First, I want to thank very much Arnold Ventures, who supported this work. They've been a invaluable funder for the work we're doing in healthcare costs. You will notice throughout this discussion, the chat box will be available. That's the way to ask your questions. We'll make sure there's plenty of time at the conclusion of this discussion to take those questions. So please be sure to just add them as you think of them, and we'll get to as many as we can at the close of the presentations. This webinar is being recorded, and both the recording and the slides from today's webinar will be available for you. So with that, why don't we jump in? I am Trish Riley, the Executive Director of the National Academy for State Health Policy. It's my honor to be moderating this event, and I'm really pleased to have with us Steve Schramm, who's the founder and managing director of Optimus, and Daniel Vila, who's the executive director of the Montana Board of Investments. I wanted to give a little background about why we're here. Most of us know that the state of Montana aggressively took action with its state employee health plan to bring down its hospital costs and its overall costs. So we wanted to give you just a little snapshot of what that situation was. And as you can see here, it was pretty dire. Health plan reserves were depleted. By December of 2014, they had lost almost $29 million. Reserves were below actuarial recommendations, and there were projections of future losses. And you know what that means. That's a danger point for a plan. The legislature in 2015 said that if the cost of the state employee health plan couldn't be contained, then state employees' salary increases were in trouble. So where the state took a hard look as it looked at where its spending was around hospital pricing, because of course hospitals make up the biggest part of anybody's health spend. The goal here was for Montana to find a better, fairer way to price and pay for hospital care. And they focused on Medicare for every facility services. Now, why did they pick Medicare as a reference point? First and foremost, Medicare cost reports are public. They're information presented by hospitals. It's hospitals' own data. Medicare is a common reference. It overcomes variation in charge masters and differences in billing practices. Of course, it's the largest healthcare payer in the country, has a very robust process by which it determines prices. It's adjusted for case mix and geography. That calculation process, that robust process, is publicly available. And it moves plans to diagnostic-related group pricing, which was important in Montana. There were, of course, constraints in Montana. The usual constraints of state procurement regulations. You can't do anything quickly, and the state needed to do so. They have no balanced billing requirements. They have very limited capacity to steer or create narrow networks. They needed quick financial results, and they needed control over future results to really change the trajectory of that slide we saw in that chart we saw in the first slide. So they went to work at developing a Medicare reference rate. 11 acute care hospitals made up the vast majority of the state health plan's hospital spend, and they focused on those, not the critical access hospitals. The key takeaway as a result of this work is that the most efficient hospitals had little, if any, change in their revenue. Well, Medicare reference-based pricing did bring higher cost facilities more in line. So what the state did was look at a Medicare repricer, examining 1 year of claims. For outpatient hospital services you see here, the range of payment for outpatient by the state employee health plan was anywhere from 239% to 611% of what Medicare paid. They identified what they called the sweet spot. If they paid around 250% of the Medicare rate, hospitals would be whole, but the state would gain considerable savings. For inpatient hospital services, you see the similar range, 191 to 322, and there they identified 220% of Medicare as the rate that would be appropriate to target a reference price to. They negotiated with all 11 acute care hospitals, and they worked with higher cost hospitals to contract for a glide path. So they saw immediate results. The state employee health plan reserves reached 112 million by December of 2017. Remember, they were at a loss point of 29 million in 2014. They required no premium increases for 3 years, and obviously salaries were in play given these kinds of savings. And those reserves became the interesting unexpected finding here is that not only were the state employee health plan reserves intact and strong, the health plan reserves were larger than the Montana Fund in 2017. So as you can see here, there is significant play. So what we thought was this could be too good to be true. This is a really incredible mechanism to create savings in a state employee health plan. So it seemed too good to be true, so we did two things. First, we hired Marilyn Bartlett, who was the mastermind with Dan Villa, our panelist, behind this reform. A CPA by training, she really took this on and succeeded in making the case. But at the same time, we want to trust but verify. So at the same time, we thought we needed a firewall and we needed to have an independent review of these findings. Would an independent actuarial review, independent of NASHB, independent of Montana, confirm that these savings were real? And that's when we launched the work that you're about to hear about to validate or not whether the Montana plan in fact had these incredible savings. And spoiler alert, it did. So with that, let me turn to Steve Schramm, who is the lead for this actuarial review and the independent evaluation, and he will walk us through his findings. Thanks, Steve, for being here.
Perfect. Thank you, Trish. Hi, I'm Steve Schramm with Optimus. I'm the founder and managing director. Optimus is a strategy and actuarial firm. We do actuarial consulting all across the country in the publicly sponsored health and welfare market. So that includes Medicaid programs, state employee plans, joint Medicaid and Medicare plans. We approached this in a 6-step process, and I'm going to walk through each one of those slides. So the first step, really, what was our objective? It was to see what the impact of Montana moving to reference-based pricing for its facility reimbursement would be. So in the way of giving you some context for this, the state employee plan is administered by the Healthcare Benefits Division in Montana. As Trish mentioned, they were having significant problems with their health insurance expenditures outpacing the revenue that they had brought in as part of their state employee plan being administered via a self-insured mechanism. That's really important to note as part of this presentation. The state employee plan moved to a self-insured mechanism because it allows them to set the premiums as well as work very closely with their contracted downstream entities on how they contract with as well as reimburse their downstream providers. The movement to reference-based pricing happened on July 1 of 2016. And as Trish mentioned, it focused on hospital inpatient and outpatient services. And what I'm going to do is talk about how we went about estimating the impact of that movement to reference-based pricing. So first, let's just give a little bit of background about what is reference-based pricing. In general, the idea behind reference-based pricing is that you pick a benchmark that exists in the healthcare marketplace. You will hear people talk about payment or reimbursement as a percentage of Medicare reimbursement. Trish already mentioned the fact that Medicare is a very robust benchmark because of its purchasing power in the marketplace. And that access to data as a result of that purchasing power allows you to use their benchmark as a linchpin, as a place upon which you can base your reimbursement. So the idea of using Medicare as a benchmark is not new, and it's not unique. You will see that happening in commercial, private health plan contracts. You'll see it in state employee plans in other states. So this was Marilyn and Dan and team looking at what are other successful ways out in the marketplace to control healthcare costs and do it in a reasonable and defensible methodology. So the idea of moving to a Medicare reference-based benchmark is a great application of a very private market concept to a public purchasing entity. So first, let's give a little bit of background. So as I mentioned, the Montana State Employee Plan was a self-insured entity. What that means is they didn't contract with an insurance carrier and get premium rates established by that insurance carrier. Instead, what they did was they contracted with a third-party administrator. In this case, it was Allegiance, and Allegiance acts as the entity that helps run the insurance program, but they're not accepting the financial risk associated with the insurance plan. That's a really important point. The state of Montana, as a self-insured entity, was assuming the risk associated with this state employee benefits program. And one of the ways that they managed that program was they used a state employee group benefit advisory council to help them get input on the plan design, the structure of the program. The benefit of using that advisory council for our purposes in doing the analysis that we did was there was a robust set of data that Allegiance provided the advisory council. And we were actually able to look at publicly available reports that existed for the time period prior to reference-based pricing. So remember, it was implemented, the beginning of the phase-in was July 1st of 2016. So we actually had 3 years worth of reports from Allegiance on the experience of the Montana State Employee Benefits Program prior to this reference-based pricing. And then we had 3 years worth of data after the implementation of reference-based pricing. And so that's a perfect opportunity for us to look at what happened prior to reference-based pricing and then after reference-based pricing. Previously, what happened was Allegiance, the third-party administrator that the state of Montana contracted with to oversee their state employee program, they paid a percentage discount off of charges for the 11 acute care facilities that Trish mentioned that the HCBD put under this reference-based pricing approach. So while they use a discount off of charges methodology, in order for us to do a comparison of what happened after reference-based pricing to the experience prior to reference-based pricing, Optimus needed to convert the experience prior to reference-based pricing to a percentage of Medicare. That way we could do an apples to apples comparison of what it was beforehand, prior to reference-based pricing, and then what it was after. And as Trish mentioned, you'll see we've rounded the percentage of discounts expressed as a percentage of Medicare, but there is a very wide range of experience. And as Trish mentioned, one of the most important things operationally that Montana did when they moved to this reference-based pricing is they established a reasonable base based on information that they had available to them for the experience in terms of reimbursement for hospital inpatient and reimbursement for hospital outpatient. The other thing that's very important to note in terms of how this was rolled out is Montana was very thoughtful about which hospitals would be appropriate to utilize for this reference-based pricing. You'll note that down at the bottom of the slide, it is very important that the group, the entity that's administering this reference-based pricing, in this instance, the Montana Healthcare Benefits Division, looks at the actual hospitals that are being utilized and differentiates. And in this instance, what Montana chose to do was exclude critical access hospitals from this pricing rubric. And that's important to understand contextually as entities, state employee plans, and other public purchasers are looking at and considering this kind of approach. You need to make certain that you think about the context that exists in your purchasing environment, and that reference-based pricing is only applied to entities that have the ability to work with you as a partner in terms of adjusting their approach to providing services to your members or enrollees, whatever the particular program is that's involved. So historically, prior to reference-based pricing, Allegiance negotiated a discount with all of these hospitals. After the move to reference-based pricing, the Montana State Employee Plan Division established reference-based pricing using these very narrow ranges for inpatient and outpatient. And what Optumas wanted to do was look at what was the financial impact of moving to that much narrower range of reimbursement. From a process perspective, what we ultimately wanted to do was look at a comparison of the paid versus billed reimbursement amounts. First, looking at what were the paid versus billed reimbursement amounts prior to reference-based pricing. And so the way we did that was the publicly available reports that the state of Montana made available through their third-party administrator, Allegiance, to their advisory council included literally a month-by-month report for hospital inpatient services as well as hospital outpatient services, a graph that showed on a per employee per month, so you'll hear us call that PEPM, per employee per month basis, what the inpatient amounts were, first the billed amount, and then second, the actual paid amount. And so let me take a step back, and you're going to ask yourself this question of, well, why would the billed amount be different than the paid amount? And the reason is that in traditional discount off of charges reimbursement, what happens is a hospital establishes a charge master, and that's what is used to determine the billed amount. And that is typically very much a higher number above what the actual paid amount is because of those negotiated discounts. So Allegiance will actually go out to the marketplace on behalf of the state employee plan and negotiate with individual hospitals and say, if your charge master is X, we're willing to pay you a discount off of that. And those discounts can be 10% or 20%, and they vary by hospital. The important point, though, about the approach of discount off of charges is that there's nothing that constrains the hospital from adjusting their charge master. And in fact, that's a very typical process that happens in a hospital budget planning process. For some hospitals, it happens annually. They actually go through and they look at their charge master and they adjust it. And so that's a completely appropriate process for a hospital to do that. But what it does is it places significant pressure upon the state employee plan because that charge master serves several purposes within a hospital. And so a charge master may increase for a reason completely unrelated to the state employee plan's reimbursement. And as a result, what happens is the billed amount increases for the state employee plan. And if the discount does not change, the paid amount is actually drug upward. It moves in concert with the increases in the charge master. So what we did was, prior to the movement to reference-based pricing, we actually looked at the historical paid versus billed ratio by looking at the paid per employee per month amount and compared it to the billed per employee per month amount. And so one of the questions that we always get asked when we do this analysis is, why did you do it on a per employee per month basis? The reason we do that is we want to remove fluctuations that are driven purely by the number of covered eligibles in the population. So if the state employee plan, the number of employees and their dependents change, that could potentially impact the paid versus billed ratio if we did it on a total dollar basis. So what a traditional actuarial technique is to control for changes in your population volume, you do your calculations on a per employee per month basis. So that's what we did by looking at the prior to reference-based pricing reimbursement by looking at paid PEPM divided by the billed PEPM. So how did we do that when we went to the time period after reference-based pricing? So remember, we had 3 years worth of data for the prior time period. So the reference-based pricing was implemented in July 1 of 2016. And so we also had 3 years of data for after the implementation of reference-based pricing. And we had the actual paid per employee per month amount. And so all we had to do was estimate what would have been paid. So we took the actual billed PEPM using the historical paid versus billed ratio to come up with what would have been paid in the absence of this movement to reference-based pricing. So we knew what they actually paid, and then we were able to estimate what would have been paid under the old historical paid to billed ratios. What you see on this slide in blue, for those of you who are following along on your computers, you'll see 3 years worth of per employee per month reimbursement for inpatient services. And then after the movement to reference-based pricing, there's a comparison of what they would have been paid. So that would have been the blue, similar to the traditional negotiation approach, which was a discount off of charges, versus what they actually paid using Medicare reimbursement on a PEPM basis for inpatient. And you'll notice a very striking difference between these two. The Medicare reference-based pricing, which if you're following along on your screen is the green hash bar, is always lower for the 3 years after the implementation of reference-based pricing. And it's not an immaterial amount. It's actually a very significant amount on a per employee, per member basis. For inpatient, over the 3 years, it's approximately $60 per employee per month, or about $30 million. So now look at outpatient. We used a very similar methodology. We looked at what had been paid, the actual reimbursement amount, using traditional negotiations. And then, just like we did on inpatient, we looked at what would have been paid in the absence of this intervention using the traditional negotiation approach as a discount off of charges. And you see a very similar set of experiences. The green hashed bar, which is the actual reimbursement once you go to Medicare reference-based pricing, is always materially lower than what would have been paid in the absence of this. And so now we have to think about, well, what are some of the potential externalities that may have impacted this difference in reimbursement? Can we actually attribute it to the movement to reference-based pricing, or were there outside factors? So you'll see some of the externalities that we, as the independent actuaries looking at this, wanted to consider. If there had been movement in these particular areas, we may not be able to say that that savings is as a result of the movement to reference-based pricing. So the first area that we'll look at is service mix. Was there a difference in service mix between the billed and the paid amounts? Well, because we're doing our calculations based on ratio, the same service mix exists in the billed and the paid amount. So we've effectively controlled for that. The other thing that's very helpful is the reports that Allegiance provides to the Advisory Council also give us a wealth of information about the underlying population risk and population mix of the covered population for the Montana State Employee Plan. And what you see is the age, the duration of individuals covered by the plan, as well as the contract, did not materially change over time. So let's talk about, why is this important? Well, if the age was different for the 3 years pre-reference-based pricing and 3 years post, we wouldn't be able to effectively compare those two without adjusting for it. But because they didn't change materially, we don't have to adjust for it. Same point about duration. It did not change materially, nor did the type of covered individuals as measured by the contract type change materially. So what that tells us is it's a very comparable data set for prior to reference-based pricing to after the reference-based pricing. Now, the other externality that we have to recognize is during this time period, Montana implemented Medicaid expansion. And that had a really significant impact on moving individuals from previously uninsured to insured via the Medicaid program. And it's grown significantly. In our review of the experience at the state employee plan, it did not materially impact the risk of the state employee plan. And so we're very confident in saying that these externalities, while they are very important in the Montana healthcare marketplace, they did not impact the amount that the state employee plan would have paid prior to reference-based pricing versus after reference-based pricing. So what do we conclude from this analysis? So from our independent review of the Montana healthcare benefits decision, the division's decision to move to reference-based pricing, when it was implemented in July 1st of 2016, phased in over time by moving from a discount off of charges to a fairly narrow range of reimbursement based on a percentage of Medicare. It had a very material impact on the expenditures of the Montana program, and it resulted in significant savings when compared to the prior reimbursement methodology. For inpatient, it's approximately $30 million over the 3 years, and for outpatient, it's approximately $17 million. So the last piece that we wanted to look at to help state policymakers think about the impact was, it is all well and good to talk about changes and reimbursement and moving to transparent pricing, but we want to make certain as we do this, it's not at the expense of access to care or quality of care. It is very important for public payers to look at their position in the marketplace and realize that they have a financial stewardship responsibility to their downstream healthcare partners. And so we wanted to also look at what the impact of this was on the hospital's financials. So again, using publicly available information, these are Medicare cost reports that these hospitals are required to submit. We looked at the time periods pre-reference-based pricing and post-reference-based pricing, and what we saw was that their financials were stable in the 3-year time period after the movement to reference-based pricing, and fairly comparable to their experience to the time period 3 years prior to reference-based pricing. And so at the end, what we conclude is there was significant savings associated with this move to reference-based pricing, and it doesn't appear to have negatively impacted the financial condition of their downstream hospital partners. So with that, Trish, I'm going to hand it back to you.
Great. Thank you, Steve. And I would encourage everybody, please add your questions into the chat box and we will get to them as soon as we can. But first, very importantly, Dan Villa is here, the Executive Director of the Montana Board of Investments, who in his prior life was a key leader in pulling this off in Montana. So back on the ground with Dan.
Thanks, Trish. I would be absolutely remiss if I didn't recognize the team effort that went into this. This was a problem, the health fund balance, our reserves, our cash burn was really a problem we identified in 2011. And a team came together, worked very, very well together. The budget office in particular, because we are a self-insured plan, Amy Sassano and Ryan Evans, while I was there in my previous role, the healthcare benefits division, Russ Hill, the former administrator. We have a wonderful accountant that's been with us from the beginning, Amber Long Thorvaldsen. So just a wonderful team. And it's sort of one of those moments where it's lucky to be better than good, or better to be lucky than good, I guess I should say, where we had the right team in place. We had the right tools at our disposal, and we really were able to use the crisis within the health plan to make some substantial changes that have benefited the taxpayers of Montana, as well as the employees. My only slide, and I'm going to talk mostly about how we did it and what we learned that the policymakers on this Zoom call can learn from. First of all, anybody that tells you that this didn't pan out or wasn't right, they're either bad with math or bad with the truth. Because you can see here, even in the first biennium, that we were able to implement reference-based pricing. We were able to take $10.5 million from what would have been general fund contributions, taxpayer dollar contributions to the health plan, the self-insured pool, and not make those. So you saw the slide earlier that said in 2017, health plan reserves were greater than the general fund balance. Yes, that was the worst year of my life. We had a special session, and part of how we got out of that financial strait was by doing this 2-month holiday, Senate Bill 3, you see here on the left-hand side. For this last biennium, the same plan was implemented again, yield $1.5 million. Now, some would say that, oh, well, this is due to less utilization, other funds coming in. The trajectory doesn't change, 10.5 to 15.5. The numbers are very linear. It matches very well with the other work that we did, because the reference-based pricing strategy was really the second big piece we did, the first being state employee health clinics. And on a PEPM, as we've been using that as a mechanism to measure, we went from about $155 in primary care visit cost to $92.52 per visit. So we've been using that PEPM as the metric since really 2011, standing up the state employee clinics, trying to control the downstream services, the referral networks that take place, and focusing on that. Alabama, Kentucky, Tennessee, New Mexico, and Missouri have all emulated what we did with clinics. And I see the questions coming up on how did we get the hospitals to sign on, and I'll get there in a second. I think the biggest thing that I would caution people about is the politics of this are very, very delicate. And I'm going to spend the majority of my time talking about that, because the best example I can give you of the politics is one of my friends works in Great Falls. He and his wife were expecting their first child as we were in negotiations. The negotiating team was Marilyn, who many of you know and have heard about. Sheila Hogan, our awesome director of Department of Administration at the time. She was so good at Department of Administration, she got demoted to the Department of Public Health and Human Services with a several $billion budget increase. And Amy Sassano, the deputy budget director, and they would parachute into these hospitals and try to negotiate the rates based on the data that Steve presented to you. And we had been down by hospital, knowing where the efficient ones were and where the inefficient ones were. And we knew the margins we had to get to in order to achieve the savings that would necessitate the general fund contributions coming down, because really the legislature told us, don't come back and ask for any more employee or employer contributions on behalf of the employees. That's just not going to happen. So we would go in and negotiate. My buddy calls me up and he says, the hospital's telling me they won't deliver my baby if we don't get a contract soon. That's the level of politics that you get into on an individual basis, that if that state employee showed their card, that employee would be told, you're not going to get your services, and they're calling whatever context they can in a panic, as their first child was not going to be able to be delivered with their preferred doctor and their preferred provider. So be very, very careful of the politics of this. The providers will use it to their advantage, and they will put the pressure back on the state or the plan, whoever. And that's why size is so important. We were able to negotiate a lot of these contracts because we were the largest still are the largest self-insured pool in the state. I think we're somewhere around 24,000 belly buttons these days. Don't quote me on that, but far and away the largest plan in the state. That gave us leverage to negotiate with regional providers, If you had one in one certain geography that didn't want to work with you, you could walk down the street and get another one. We were lucky that Montana's one large town geographically with very few people in it. So as the hospitals talk, do you have a contract, do you not have a contract? We were lucky that everybody eventually got on board. You also have to be careful that you have to, the rewards are delayed. You negotiate a contract in 2016, 2017, you don't see a lot of those financial benefits until later, because as you saw in Steve's presentation, that PEPM gradually phases in. So if you're expecting a very quick turnaround, it's going to be, it will result that will be there, because at the end of the day, what you're negotiating with reference-based pricing is, instead of going from a ceiling that's artificially set by a third party with, as it was in Montana, a request for proposals to who could get you the largest discount on that unofficial, uncontrolled, not transparent ceiling of price, down to a DRG, very well known, very accountable, publicly available pricing structure. You're then able to show not only the taxpayers, but your employees what they're paying for and what they're getting. But that takes time in order to achieve those benefits and those rewards. It won't be overnight, but it is absolutely worth the cost, as you see in this independent analysis. The funds are not necessarily fungible. As these fiscal notes, it did take legislation in order to move the money around. So for those of you in the legislative realm or the budget director realm, if you are making contributions on behalf of those employees, if you're able to implement cost savings like this, you've got to be prepared to be creative about how you get access to those dollars. Do they sit in the pool, build excess reserves? Are you able to take advantage of them in other pots? If you are, how do you message that? We had to have a number of conversations with our employees. No, we're not raiding funds. Everything's fine. You still have your resources and reserves, but those dollars are needed elsewhere. And at least in the case of 2017, it was sort of a, look, we're going to minimize the amount of RIFs we have to do, or employee reductions or additional workload we're going to shift on you by simply not making a contribution to your health plan, which is already at a very healthy place. And then the biggest aspect of this, which anybody that was on the Monty team can tell you, data, 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 data. It is all about the data, the amount of charts and spreadsheets we were able to pour over, utilize, manipulate to show what we needed to get to from where we were. We had the graph of Montana with how many hospitals are within so many miles of our employees, what are they charging, what rates do we need them to get to in order to realize the targeted savings. Use your data, think outside the box about how you do it. Don't necessarily be confined to what's my total premium payment, what's my total contribution on behalf of employees. Is frankly, those of us in the legislative or executive realm, budget office realm in particular, think of it in terms of aggregates. You really do have to get down to the PEPM, identify your high cost hospital. If you have a high cost hospital that doesn't have many employees around it, you're not going to spend a lot of your time on that particular hospital. You're going to want to focus on those that you have the largest gain based on the actual spend you have with those facilities. I absolutely believe this can be replicated. I know some troubles with it. A couple of pieces of advice. Use your entire field of play. Don't just confine yourself to, sorry, my internet connection is unstable. Son must be on YouTube again. Don't confine yourself necessarily to the state employee plan. Legislators have access to the entirety of the policy arena. Budget directors have access to the entirety of the reimbursement system. $1 in is $1 in, regardless of what the color of that dollar is. Is it a pink Medicaid dollar? Is it a state employee dollar? Is it a green, municipal dollar? Use the entire field of play, build your partnerships, build your networks, so that when you are negotiating these, it's not just you and an individual group of state employees, it's you and the local largest municipality who also happens to be self-insured. It's you and one of the private sector employers in the region. The state of Montana was a part of a large healthcare purchasing coalition. We had the Bankers Association was a part of it. The largest regulated utility is a part of it. The Montana Association of Counties, the Montana League of Cities and Towns. Your networks can bring additional leverage to the table for you, so that if they see your state employees are just a small portion of the payers in that particular geography with that hospital, you can potentially work with other large employers in that area in order to leverage the ability to get a better price. Your messaging is critical. In 1968, Forrest Anderson was elected governor of the state of Montana based on the message for pay more, what for, rallying against a sales tax. Incidentally, Montana still sales for a nice post-COVID vacation spot. Come visit. It's very difficult for providers. Again, the sort of triangle of providers, patients, payers. It's very difficult for those providers who set their charge masters to argue against transparency and accountability in the pricing structure. We want to know what we're paying for. We want to know how much we're going to pay for. Those are very easy things to message, and taxpayers understand that. In this case, legislators understood it very, very well. We negotiate these contracts under a Democratic governor with an all-Republican legislature. These two pieces of legislation you see up are sponsored by a Republican legislature. The benefit of that messaging and the simplicity of it, we want to know what we're paying for, we want to know how much we're paying and where we're paying it, is very difficult to argue with, particularly when you're creating those savings for taxpayers. I mean, $26 million in just these two pieces of legislation alone. And the last piece of advice I will give you is avoid legislation if you can. The healthcare system is rife with lobbyists. They have providers in every legislator's hometown who won't want to negotiate with you to lower prices. Use your procurement laws, use your ability to negotiate contracts independent of a legislative process to the greatest extent you can. When we started down this road, we originally had legislation that said the legislature was directing the executive branch to implement reference-based pricing. It was literally a 5-minute break in the end of session negotiations on the budget when the lobbyists heard about this, that they came back with, well, we have a suggestion that you implement reference-based pricing. We called it the Thelma and Louise strategy, because if the executive drove off the cliff and it didn't work out, the legislature was very eager for it. But since it did work out, they've been more than happy to take all of the credit, including one individual legislator who was in the room negotiating, put it in his congressional ads about how he implemented reference-based pricing in this. Make sure that you use your executive authority, for those of you in the budget office, health plan world, to the greatest extent you can, because there will be amendments, there will be opposition if you go the route of legislation itself that you can avoid through just the contracting processes you already have. So I will turn it back over to Trish and answer questions.
Yep, great. And we've got a bunch that come in the same sort of category of skeptics. North Carolina tried to do this. Their hospital pushback was incredible. They were not successful. We've had some other states asking, how did you get the hospitals involved? North Carolina is an example of not getting them engaged. Could a small state like Vermont that has 2 academic medical centers make this work? What about, where did the savings come from? Did they come from your big academic medical center? Were they spread across the state? A big set of questions about how do we get the hospitals on board?
So first, we don't have academic medical centers in Montana. We are witchy, whammy, wooey, Washington. So most of our medical school and medical education takes place out of state. But again, this is, and this is Dan Villa, retired budget director, not Dan Villa, Board of Investments director. Use the entire field of play. If they are receiving state funds, you've got an avenue. If they are, if there's a large municipality in that area who's also self-insured, partner with them in order to get a lower price. Go in and negotiate one contract for two entities as opposed to just one contract for yourself and someone else. We were able to achieve a lot of savings because we had not only the employees rallying behind the efforts we were going down, we had legislators pushing us to achieve these savings, but we also had municipalities, counties, other entities who were payers wanting to join in with what we were doing. So you've got to build that broader base and that broader network to ask for the costs. Whereas if you just go it alone, and again, I don't know the instances or the individual aspects of what one state did, but the partnership, the size, and utilizing the entire play available to us in the executive were sort of the three critical aspects of how we were able to get there.
And did your biggest hospital come up with most of the savings? Is that how you achieved the savings?
No, the biggest hospital, it depends on where your employees are. So for us, the biggest hospital was not the biggest saver. It's where the most number of employees were and where we were paying less on an individual PEPM than where it was just the biggest hospital.
Anything to add, Steve?
From an actuarial perspective, a small state like Vermont, even with a fairly concentrated hospital market, what Dan just said is the key. If there are variations in reimbursement between and among hospitals, that's where reference-based pricing really shows its power. It is not that it drives savings as the end result, in as much as it narrows the variation and allows you to say, look, all of my hospitals need to be equally efficient. And that's not size dependent. That could happen in a small state like Vermont, or a large state like Texas or California.
And the compelling thing is that range of how Medicare reimburses today. We at NASHP have a cost tool based on the work that happened in Montana that can help states. If Vermont, and I think maybe we have, if Vermont wants more information, that's information we can run so that you can do those comparatives. We've only got a few minutes. I want to get through these questions. The big elephant in the room is always cost shift. Did in succeeding in getting lower rates for state employee health plans, did other payers pay more? It's a big debate in healthcare. I would commend to all of you work by Austin Frakt, F-R-A-K-T, at BU, who basically argues hospitals charge what the market will bear, less than cost shifting. He argues that cost shifting is not a compelling issue. But were we able to tell anything, Steve, to answer the question?
Unfortunately, the data that goes to the council, those data are not sufficiently detailed to allow us to see if there was any cost shifting. But we can look at the cost reports that are filed, and again, publicly available. And what you see are differing approaches by the major hospitals. And I think this reinforces what Dan said is some hospitals accepted a reduction in revenue, and you can see that in their cost reports. Others focused very much on reducing their expenditures, so they became more efficient. And what I think the power of this is, you have the ability, notice that Montana still used a range as a percentage of Medicare. So and phased it in over time. You have the ability to partner with your hospitals and say, what can you do, and what is your approach to make this reference-based pricing work for you? So I don't think you can definitively say there was cost shifting.
Okay, and we will, in the materials that we send out and post for people, will include reference to the FRAC study and information about the cost tool and a webinar we did earlier on how to use it. So the help is here to do what Montana did. Again, the politics of the challenge. Do we know if the state continues to do reference pricing over time, and if so, what trend line they're using, what they're expecting, Dan?
Probably a better question for Steve. I know the contract still exists. They were up for negotiation last year, but I actively wipe my hands of budget office work when I move jobs.
From a purely operational perspective, one of the benefits of moving to a self-insured environment and using reference-based pricing is, while you can hold your percentage of Medicare constant and therefore peg it to Medicare's annual increases, you also have the ability to adjust the percentage of Medicare that you do pay so that it's a trend line that you think is appropriate and you've been able to negotiate jointly with your hospital partners. So it actually gives you the flexibility of, do I want to strictly benchmark to Medicare, or do I want to have some flexibility and potentially adjust the percentage that I pay of Medicare?
And before the reference-based pricing, Dan, did you pay hospitals DRG, or was that part of the reference-based pricing?
No, we had the sort of traditional third-party administrator we'd put out the bid, insurance company X would negotiate their discount. We would judge based on administrative costs and greatest amount of discount. This really flipped that on its head. We built from the ground up. The other piece, how we did prescription drugs, which is a whole other thing that I know you're well aware of, but the concept of letting someone else set what you will pay on an annual ongoing basis, independent of your knowledge or participation, no one would buy a car that way. No one would buy a house that way. So we asked the question, why would we pay for healthcare that way?
And just to confirm, you didn't touch prices in freestanding ambulatory surgical centers or facilities? Is that correct? Okay.
No.
Negative. Okay.
That was part of looking at our network and where the cost savings would be. And it was, the cause, there wasn't a lot there. But when you look at those large, it's really 11 hospitals in Montana where we were able to achieve the majority of the savings.
Well, we are perilously close to time, so I want to thank very much Steve Schramm and Dan Villa for this great presentation, and to tell all of you, there is data and information available for you. We can help you run data like this, and the best way to start the conversation with your hospitals is to look at the data. It's self-reported data from the hospitals, and it's a great starting point to talk about how much you should pay. So with that, we're very pleased that we had this independent actuarial analysis. We now have the capacity, knowing that there's real money in them there hills, to be able to go out and help other states implement reference-based pricing. So we encourage you to contact us. And with that, I thank Arnold Ventures, Dan Villa, Steve Schramm, and thank you all for participating.